Welcome back, everyone. We're going to continue our discussion on the pediatric series by looking at pediatric patient assessment and the PAT, or Pediatric Assessment Triangle. Pediatric patient assessment is going to differ from adult assessment, particularly in your approach and then understanding your findings as how they relate to the pathophysiology or the presentation of that patient. You need to adapt your assessment skills accordingly and make sure that you have appropriate equipment and you're evaluating for age-appropriate vital signs. Scene size up is important with the pediatric patient, just as it is with every patient, but the important thing, which we'll talk about here in a moment with the pediatric assessment triangle, is observing the patient in their environment, and that appearance and how they look and how they respond to that environment can help provide some subtle clues into the acuteness or presentation of that patient. Make sure that you collect information from dispatch, but you're mindful that the information from dispatch is only going to be the information that was conveyed from those on the scene. And so if there are no medical providers on scene and you're getting information from a layperson, that information may be contaminated or may not be fully accurate. And you should go into every scene with that assumption and make sure that you're assessing accordingly and not just looking at the information provided as dispatch for your history. And make sure you take your appropriate standard of precautions, right? Note the child's position as you approach the patient. Is the patient flaccid? Is the patient moving? Are they engaging with the environment? Make sure you note each of those and utilize that to paint a broader picture of patient presentation. Note any pills or medicine bottles, alcohol, drug paraphernalia, or household chemicals that are in reach for the child, as scene contamination, scene hazards to the patient can lead to poisoning and should be a clue for what's going on. And then make sure you just look for other clues within the area. And this is true with every patient, but also true with pediatric patients, looking at things like structure of the house, cleanliness of the house, things that can cause harm. Is there food present? Is malnourishment a concern? If infant is nursing and mother is not acquiring the appropriate nutrition, then that can lead to malnutrition with the neonate. So make sure that we're just taking into account the things that are going on that may play a role into that patient. The primary survey, we're going to use the Pediatric Assessment Triangle, or PAT for short. And there are three sides to that triangle that we look at. We look at first the appearance, then work of breathing and circulation of the skin. We use this tool partly because pediatric patients compensate really, really well, and we can gauge their sort of acuteness, if you will, based on compromise to the circulatory system and where we tend to see those first. And large consumers of oxygen within the pediatric patient are the brain and the heart. So we may see things like altered mental status or dysconjugate gaze or non-attentiveness to the room or lethargy. And then circulatory, the pallorness of the skin may indicate that there's just not an adequate perfusion there. And work of breathing is one of the compensatory tools to ensure for oxygenation. So with appearance, it's often the most important factor in determining the severity of illness. You hear a lot, or we hear a lot, or say a lot that a crying baby is a happy baby, and that's true to some extent. Irritated, crying babies are a better sign than somnolent, dysconjugate gaze type infants that just aren't looking at their environment. So we're looking at things like tone. Tickles is the mnemonic that's often used. Interactiveness, right? How alert the child is. Consolability, how well they can be consoled, or is it an inconsolable cry? Their look, gaze, and then their speech or their cry, and how strong that is. A child with grossly abnormal appearance requires immediate life support interventions, and you can see here kind of a gaze that's intact from an infant on the left-hand side of your screen, and the right-hand side of your screen is obviously lethargic, has that dysconjugate gaze or that staring off into space. You further note retractions, suprasternal or substernal retractions that are just above the abdomen there. So you've got some increased work of breathing going as well. Work of breathing reflects the attempt of the patient to compensate for abnormalities in oxygenation and ventilation. Things that may clue you into an increased work of breathing during that primary survey are abnormal airway sounds, snoring, muffled or hoarse speech, stridor, grunting, wheezing. Posturing is also important. So we talk a lot about tripod positioning. Infants can't tripod, but watch for positioning and sort of how that infant is lying or moving itself. You can look for an anterior rotation of the shoulders kind of inward. And we'll show some image of tripoding here in just a moment. Retractions, these are really important. So remember that through normal ventilation is a negative pressure ventilation process. As the diaphragm flattens, it reduces the pressure in the thoracic cavity, causing air to rush in. When air is obstructed, when it can't get into the lungs, the tissue will also retract with that negative pressure. And so that's where you see these retractions come from. So supraclavicular is above the clavicle. Often can be seen and easily inspected even with clothes on. So it's a quick glance that you can kind of look around the collar for supraclavicular retractions. Intercostal and substernal retractions, you need to expose the patient to be able to see those. And head bobbing in infants is also an ominous sign, so just be mindful. And then nasal flaring can be important as well. Here you can see some examples of tripoding. So with tripoding, it's not just sort of sitting down and putting both hands on the ground, but the shoulders are rotated anteriorly and sort of lifted up toward the ears, like you can see in that middle picture there. And that's done to create a larger volume of space in the thoracic cavity. So it's a subconscious response to increasing the volume of the thoracic cavity to attempt to get more airflow in. A picture on the right is another picture of substernal retractions there that you can see. Circulation of the skin, this determines adequacy of cardiac output and core perfusion. You're looking for things like pallor, paleness, modeling of the skin, or cyanosis. Using the findings from your pediatric assessment triangle, then you should be able to determine your your transport modality. We talked a lot about this in patient assessment. Based on your primary assessment, your assessment of ABCs in the normal adult and level of consciousness, your pediatric assessment triangle, you should be able to determine the acuity level. Are they using things like the CUPS acronym, right? Critical, unstable, potentially unstable, or stable, to be able to determine, do we finish this assessment and treatment in the truck, or do we have a minute to be able to stay on scene? Or perhaps the third option is that they are so critical that you need to intervene on scene before you go anywhere or do anything. Hands-on primary survey, right? Manage threats to ABCs as you find them. If the patient has insufficient ventilation, ventilate your patient. Steps are the same with adults. You can estimate the child's body weight using a length-weight-based tape measurement, or length-based weight measurement system. Broslow was the common one for forever, but there are others present now. For airway, determine whether the airway is open and the patient has adequate chest walls. If there's a potential obstruction, position the airway. Suction is necessary. Basic interventions are always first, and then we move progressively based on your skill level to more progressive interventions. But by and large, most of the time, basic interventions are going to manage these patients' airways. Breathing, calculate the respiratory rate, right? Observe for chest rise and fall, auscultate breath sounds, check pulse oximetry and oxygen saturation. And I would argue that with oxygenation and circulation, you should also be assessing end-tidal CO2 if possible for these patients. Integrate information from the pediatric assessment triangle, listen to the heart and feel for pulse for at least 30 seconds. After checking for the pulse rate, then do a hands-on evaluation of the color and temperature of the skin plus the condition of capillary refill time. For disability, use the AVPU scale, right? This is the alert to verbal, alert to pain or unresponsive. The scale is going to be the same for adults as pediatric patients, but what will change is when we look at things like the Glasgow Coma Scale. Because particularly in the verbal response for Glasgow Coma Scale, we use things like oriented speech or confused words. So you can see here for infants, in the verbal section of the Glasgow Coma Scale, we're looking at things like an irritable cry or a cry to pain or a moan to pain. And then in the child, we can use more of the confused conversation using age-appropriate assessment techniques, right? If they don't know words, then you can assess their words. Cries or uses inappropriate words, moans, incomprehensible words or sounds. So there's some variance there, and we need to treat that accordingly with your pediatric patients. For exposure, right, perform a rapid exam of the entire body, but make sure we're avoiding heat loss. Preventing heat loss isn't an excuse to not assess your patient. Expose the patient, then cover the patient. So you still need to be exposing and assessing your patient appropriately. If there's a significant mechanism of injury, right, transfer it to an appropriate trauma center. Note any physiologic abnormalities or significant anatomic abnormalities, or things like an unsafe scene. These may all indicate or dictate an immediate transport away from the scene, even if the patient may not be significantly critical or acute. For history taking, usually we're going to conduct this en route, especially if the patient is unstable. Sample is a great jumping off point for assessment for your pediatric patients, but your patient's going to be a poor historian, first of all. So you're going to need bystanders, caregivers. So it's common practice to take a caregiver with you to the hospital so you can gather that additional information. Secondary assessment, we're going to use the same sort of pathway as we do for an adult patient, right? Assess the most likely impacted organ system based on your assessment findings, and then work your way to the next most related system to develop a full diagnosis and differential diagnosis for potential causes to the underlying presentation. You can attempt to take the child's blood pressure, although the blood pressure is not always the most accurate assessment, especially in very, very young patients, for cardiac perfusion. Things like skin perfusion, perfusion of the conjunctiva of the eye or the oral mucosa. So assessing the conjunctiva of the eye or looking underneath the tongue or the oral mucosa and looking for blanched skin and capillary refill is going to be a better indicator more often than not than just blood pressure by itself. So use blood pressure and get a blood pressure accordingly. However, use it in conjunction with your other signs and symptoms and presentation. Remember that blood pressure compensates for a long period of time for pediatric patients and then will decompensate very rapidly. For minimum systolic blood pressure, you're looking at 70 plus twice the age in years. And so when we look at an adequate blood pressure for a 4-year-old, it would be 74, right? 70 plus 2 times 2. So that's a good, easy way to kind of get you a minimum adequate blood pressure for those patients. When assessing pain, pediatric patients often can't tell you directly their level of pain. And so you're going to need to use other clues to assess a patient's age, and especially their developmental age, and discuss pain with their caregivers, because they're going to have a better indication. A patient's full-time caregiver is going to have a much better indication of their normal presentation and what their baseline is. So you can consider pain management in conjunction with discussing with the family, and you can use things like the Wong-Baker FACES pain rating for children or even adults that can't articulate levels of pain. Pediatric pain is no different in adult pain in that pain should be managed appropriately. If the patient is in significant pain and it's going to create a barrier to healing and health, then we treat pain, period. It doesn't matter the age. We don't just not give pain management because it's a pediatric patient. You can use pharmacologic methods. Remember, we have things at the basic life support level as well. So for trauma, things like splinting can reduce pain. Reduced mobility can reduce pain for those physical injuries. You may consider things like acetaminophen, although in the prehospital world, that's more predominantly used for temperature control as an antipyretic. But you've got things like opiates and other medications at your disposal based on your certification level. For reassessment, use Pediatric Assessment Triangle, right, and reassess accordingly. If you're not treating your patient and you're not doing anything else, then you always should be reassessing. Assessment is an ongoing process. It's not something you do and then forget and then just come back to so many number of minutes later. It should be a continual reassessment, particularly if you're giving interventions, and you should be reassessing the impact of those interventions on the initial presentation for the patient.